My name is Christina Jadushitsky. I'm the founder of New Life Physiotherapy, and I'd like to welcome everyone to tonight's seminar on the physiotherapy approach to rehabilitating and rehabilitating prostate cancer surgery patients. I'd like to extend my gratitude and a big thanks to Prostate Cancer Canada for allowing me to speak today. It's always a pleasure talking about the benefits of pelvic floor physiotherapy and raising awareness about this highly effective treatment option for the management of some of the side effects that men will or can experience after having their prostate removed. Tonight's meeting is going to run about 45 minutes. We're going to take a couple breaks at about the 20-minute mark and then again at the 30-minute mark so that you guys can go and empty your bladder. And then at the end, we're going to actively participate in learning exercise protocols that I teach my patients when they come for their pelvic floor physiotherapy appointments. So I'm a registered pelvic floor physiotherapist, and I work with men, women, and children who suffer from various conditions. And I decided to specialize in men's health several years ago when I first found out that men's health lags behind that of women's health by approximately 30 years. But then also when I was provided with the opportunity to work with several surgeons in the greater Hamilton area who specialize in urology and prostate cancer surgeries, where I not only had the opportunity to spend days with them during their clinical hours, but I also had the opportunity to observe them performing these prostate cancer surgeries. And it was when I was able to combine this knowledge that they provided me with knowledge that I had acquired from my own ongoing education courses after I had graduated from my master's degree in physiotherapy, as well as my 21 years of committed passion to health and fitness, that I was able to create these unique exercise protocols for men who are suffering from the consequences of having their prostate removed. And I've been having quite a bit of success with these protocols. So naturally, after having seen some success, I decided that it would be time to enroll in the PhD program so that I can further the research in men's health. And fortunately, Dr. Shagan from St. Joe's, who's one of the leading urologists and teaches the robotic procedure across North America, decided to take me on as a PhD student. So I'm excited to start that journey in January of 2021, and I hope to make some big differences in terms of how we're currently treating men and providing care for men who are suffering from the consequences of prostate surgery. I'm really excited to share some of that stuff with you guys this evening so that you too can benefit from what my patients are currently benefiting from. All right, so without further ado, we're going to get started into our presentation now. And I always like to start my presentations off with a little bit of interesting facts. So first of all, did you know that 3.5 million Canadians suffer from urinary incontinence? Of these, 1 in 9 men experience urinary leakage, and prostate surgery is the most common cause for this. And it can take anywhere from 6 months to a year, roughly, to regain continence. Furthermore, 60 to 70% of men will have long-term erectile dysfunction post-prostatectomy, and the recovery for this can take up to 4 years. Don't fret, all of these timelines can be improved with pelvic floor physiotherapy, and they can be significantly reduced by up to 6 to 9 months. So there's definitely hope, and you don't have to live with the consequences of incontinence or erectile dysfunction for quite as long. Tonight's presentation objectives include going over some of the things that you should expect after having prostate surgery. Why do these side effects occur? And then how does pelvic floor physiotherapy improve the outcomes? And then, as I mentioned, we're going to go over an evidence-based exercise protocol for pelvic floor muscle training. All right, so what to expect after prostate surgery? The first two, urinary incontinence and erectile dysfunction, those are really going to be the bulk of tonight's presentation. But these are definitely the two most common side effects that can happen. And we're going to talk in much more detail about these two conditions. But there are other things that my patients wish that somebody had told them before they had the surgery or shortly thereafter that tend to get overlooked. And so I'm going to include them here tonight so that you're all aware and not worried, because I find that men think that, oh, maybe something's wrong, maybe the cancer came back. It gives them a little bit of anxiety when they weren't forewarned, so to speak. So the loss of penile length, in this video, or in this picture here, you can see that this man's penis has almost completely retracted into the base of his penis around the pubic bone region. And this man will have to sit to pee because there's no more length in his shaft. And that happens for two reasons. If you look here, I'm just going to get my pointer out. If you look here, this is the prostate. Okay, and that's just below the bladder. So you've got the bladder here, you've got the prostate here, and then you've got the urethra traveling through the penis. When you get your prostate removed, the prostate's about 2 to 3 centimeters in length. So when you get this prostate removed, they have to reattach this bottom part to the base of the bladder neck. So you're going to, at the very outset, lose about 2 to 3 centimeters, and sometimes more if your prostate's larger, of length, just because of the reattaching process. But then there's a progression that goes on, because there is a process which we're going to get into a little bit later that starts to occur, and structural changes start to happen to the penis due to the erectile dysfunction that men experience. And the penis will start to shorten as a result of those structural changes. And we're going to get into that in quite a bit more detail. The other thing that can happen is Peyronie's disease. So in this picture here, you can see that Peyronie's disease is a curvature in the penis due to fibrosis, which is basically development of plaques. And it starts to develop like a scar tissue situation where the penis starts to bend. And these bends can actually become quite severe in that a man will no longer be able to penetrate, and having erections can be quite painful. 1 in 6 men will experience this following surgery, and it starts to appear at about the 14th month after having had the surgery, whereas 1 in 8 men will experience the Peyronie's disease after radiation, and this will appear much later, closer to the 3-year period, and that's because radiation has a longer term effect to the cells, because the cells continue to degrade over time or change over time, and they start to lose their elasticity or their stretch. And as a result of that, this can start to occur in men who have undergone radiation as opposed to prostatectomy. A couple other things that men tend to be concerned about and that aren't always discussed with them at the outset is dry ejaculation. Nothing's going to come out anymore when you have an orgasm. The plumbing essentially has been cut. So this picture is not exactly where the cut happens, but it is the best picture that I could find to explain what I'm trying to explain to you. The cut actually is going to happen behind the bladder, where they're going to remove the seminal vesicle along with the prostate. And as I mentioned earlier, they're going to reconnect the membranous urethra portion here to the bladder neck. So if all of this plumbing is removed, then you're not going to have any more semen or fluid coming out of the penis when you ejaculate. The seminal vesicle and the prostate are responsible for producing a good portion of the ejaculate that comes out from a man's penis. And so if these areas are removed, then naturally you're not going to have the production of fluid. There are, however, 2 bulbal urethral glands that sit on the other side of the prostate that are still remaining. And that's kind of that pre-cum that men are perhaps familiar with. And you might still have that coming out when you have an orgasm. But anything else will not be coming out. So it might be a little bit problematic for men because it kind of changes the experience that they're used to. But for your partners, it might just mean it's not so messy. So climacturia is the involuntary loss of urine during arousal and or orgasm. And that happens because in the prostate, there's a little valve that blocks off the bladder when a man is having an orgasm and ejaculating. And naturally, as you remove that prostate, you're going to have to you're going to be more exposed to having leakage because that valve that would shut off the bladder is no longer present. But with pelvic floor muscle strengthening, it will improve. And this can occur in approximately 30% of men. Some of the risk factors for the climacturia, or the loss of urine with arousal or orgasm, is obviously the time since surgery. So as time goes by and you work on those pelvic floor muscles and they regain their strength, this will start to reduce. And if you've ever had any prior TURP surgery, so that's the basically the resection of the inside of the prostate, if it was enlarged and it was preventing urine from coming out, and also a shorter urethral length and penile length. So those factors can definitely make you more at risk of having this condition. Other treatment options beyond pelvic floor muscle exercises would involve emptying your bladder before having sex, wearing a condom to catch the urine, or using a penile variable tension loop. And in this picture below here, you can see the tension loop at the base of the penis. It doesn't compress the penis so much that it's cutting off the circulation. All it's doing is that it's just here, the urethra is located right here. And so this variable tension loop, all it's doing is it's just squishing a little bit on that urethra to basically close down the urethra so that there's no fluid that comes out when having intercourse or when being stimulated. Right, so let's get into post-prostatectomy incontinence. Who's at risk for post-prostatectomy incontinence? Older patients. If you don't use these muscles, you lose these muscles. And if it's been a long time since you've used these muscles, then naturally those muscles are going to be significantly weaker. And we're talking about patients, you know, over the age of 70, 75, and that's when they start to be much more at risk for leakage. A larger prostate size is also another risk. And that's because here, if you can appreciate, this is the bladder and this is a normal prostate. And you can see the inside of the prostate, you can see the urethra is running through the prostate and it's very well open. So when the bladder contracts, it can empty its contents quite nicely. But if you have a larger prostate, what starts to happen is that the urethra gets pinched. And now what happens is the bladder has to generate so much more pressure to try and empty its contents because the pressure inside here is much greater. And then what happens is that the bladder starts to develop this kind of habit of always trying to squeeze really, really hard to get rid of what's inside. And it gets into this wrestling bladder kind of syndrome, we call it. It's almost like an overactive bladder. And it doesn't get the memo. When the prostate gets removed, it doesn't just all of a sudden go back to what it was in its healthy state. It still has the same habit that it developed while the prostate was enlarged and it was squishing on the urethra. So it's going to continue that habit. And so having a larger prostate size will put you more at risk of having something called urge incontinence, and we'll talk about that in a later slide. Also having an elevated BMI. So if you're trying to learn how to do a squat, you're not going to put 100 pounds on your back to start learning how to do a squat. You're going to do an air squat. You're going to learn the proper technique and form before you start loading it. So when you are now going to be using muscles that you haven't been using for most of your life, and we're going to explain that in just a moment so you can get a better understanding of how that works, you don't want to put extra weight onto those muscles because they're not muscles that you're used to using. So you have to give them time to get stronger. So having extra weight on is going to make it a little bit more challenging for you to maintain some continence. And then the final thing is having a shorter urethral length. So this unfortunately is genetics. There's not much that we can do about that, but this portion here is the membranous urethra, and this is what's going to be left after you've had the prostate removed. And the longer this piece here is, the better chances of being continent you're going to have. So if you can imagine, if you had a urethra and you wanted to close or squish it to prevent leakage from coming down, if you only had 2 fingers that could do it versus a whole fist, well, the fist is going to be much more effective because it's going to cover more surface area and it's going to be better at closing down that urethra. So having a longer urethra will help with that. So what causes urinary incontinence? So the removal of the internal sphincter. All right, let's look at this picture up here. So we've got the bladder neck here, and this is where that internal sphincter is housed. So it's housed inside the prostate, and this internal sphincter is your primary worker. When the bladder fills, when there starts to become urine or entering into the bladder, that sends a signal to the brain to contract the internal sphincter. And notice that I said it sends a signal to the brain to contract the internal sphincter, because we don't have control over this muscle. So this is a muscle housed inside the prostate, and it's a smooth muscle. And we have to understand the difference between smooth muscles and striated muscles, because the smooth muscles is the one that's going to get removed, but we are going to be left with the external striated muscle that's just on the other side of the prostate. The difference is that a smooth muscle we don't have control over, and a striated muscle we do have control over. So let me give you some examples of a smooth muscle. The bladder itself is a smooth muscle. You can't tell your bladder, okay, bladder contract. Your brain is responsible for that. Or for example, the blood vessels. You can't tell your blood vessels to dilate. They dilate in response to your brain's command. Your colon, for example, it also will contract and try to push food through, but not when you're saying, okay, get the colon, start to digest. We don't have that ability. So those are all smooth muscles that are under the control of the brain. The striated muscles are like the muscles here in our arm. If I have my arm out like this and I say, okay, I'm going to bend my elbow, well, I'm using my bicep to bend that elbow. So these are all striated muscles. All the muscles that move us and we can voluntarily do it, those are striated muscles. And fortunately, the design is the way it is. The anatomy was put together quite nicely, because when we have prostate surgery, we lose this internal sphincter, and now we become 100% reliant on that external sphincter. And that's why I said that if you have extra weight on and you're now reliant on this guy who's only really ever been a helper throughout your lifetime, because this guy has been able to do most of the work for you. In case, let's say, the bladder was really, really full and it wasn't appropriate to pee, then you would squeeze this muscle to help maintain continence. And so it's like this double lock mechanism that you had. And now you're down to a single lock, and you have to build up these muscles so that they become able to basically take on 100% of the role. The other thing that can happen is that you get damage to the external sphincter. So if we look over here, this is an open laparoscopic procedure. The man's been cut, and then you can see inside. And what happens is the external sphincter, so that's the same thing over here. You're seeing this, and now you're seeing it down here. There's an anastomosis process that happens. So it's the joining together of the bladder neck to that external sphincter, and it gets sutured or sewn together by 6 little sutures. In doing that, you could traumatize the external sphincter temporarily. And then sometimes if the cancer is spread a little bit further, they might have to take out some of that muscle too. So there's some cases where that might happen. And then you're going to be relying on muscles that are not necessarily the most mechanically efficient ones to maintain continence. I'm going to say a quick word on this, because this was my big aha moment when I was in the surgery room watching the robotic procedure being done. And I was watching Dr. Shagan suturing the base of the bladder to the membranous urethra. And all I saw was 6 little sutures connecting these 2 areas together. And then a catheter, which is this yellow thing that you see, was inserted to make sure that there was enough space for urine to flow. And that catheter stays in for about a week after you've had the surgery to make sure that the healing occurs properly. It was when I saw that I realized, wow, you do not want to be lifting more than 10 pounds after the surgery. And this is something that's told to men. But after you've had the robot procedure done, it is so minimally invasive. You don't get cut like this, like the open laparoscopic surgery or the open surgery. You don't get cut open like this with the robotic. All it is 6 little incisions, and that's it. When you get out of surgery, you feel great. And so you might think you can lift more than 10 pounds, but the same thing is happening regardless of what kind of surgery you've had. And you've got to be very mindful that you want to give it that good 8-week period where you're not pushing that 10-pound limit that they suggest to you. I just thought that was really important, because I definitely make sure my patients are very aware of that fact. Okay, and then the other thing that can happen is that you'll have this increased demand on the striated muscles. So as I mentioned, these guys become 100% responsible for the work now, and if they're not conditioned, then you're likely to have urinary incontinence. So the types of incontinence, we touched on one of them, the urge incontinence, and that was kind of that overactive bladder. We'd mentioned that the bladder kind of gets into that wrestling bladder situation, and this occurs due to an inability to suppress a sudden strong urge to urinate long enough to make it to the toilet in time. Okay? And it can happen in any position. It's unexpected and unpredictable. So this can be managed with medication or pelvic floor muscle exercises if you're looking for more conservative options. And a lot of the times it's about learning how to down train the pelvic floor muscle as opposed to always strengthening. Sometimes it's a matter of learning how to let go, and we call that a reverse Kegel or a reverse nuts to guts, which we'll get into in a little bit. The primary one that we experience, though, is the stress urinary incontinence. And this is leakage of urine as a result of an increase in intra-abdominal pressure. So when you cough, when you laugh, when you jump, sneeze, getting in and out of a car, anything that would put more demand on the abdominal region and more pressure on the pelvic floor, that will result in leakage just due to insufficient pelvic floor muscle strength. And naturally, the treatment for that is to train that pelvic floor muscle. And then the other one that we don't see as often, but we certainly do see, is overflow incontinence. And this is happens basically when there's an obstruction due to scar tissue formation at the bladder neck. And basically the bladder fills so much that it just can't hold anymore, and you're going to naturally get some dripping out as a result. This is, however, a medical emergency, so you'll want to go and see your doctors if anything like this pops up. There are other things that you need to consider when trying to regain continence beyond just pelvic floor muscle exercises. You'll want to remove bladder irritants such as caffeine. Caffeine is a diuretic and also a bladder irritant, so those things may QP. And alcohol is also a diuretic, so it'll also make you pee. But the other really interesting thing about alcohol is that it relaxes the striated muscles. And remember, you are now 100% reliant on that striated muscle that's left after you've had the surgery. And if you drink quite a bit, you're basically going to put it to sleep. So if you are going to drink, just to be cautious, I would suggest you maybe wear a pad or a shield to avoid potential embarrassment. Cigarettes, obviously we know they're bad and they're going to delay healing. Spicy foods, a bladder irritant, cow's milk particularly, that's also going to cause some inflammation and irritate the bladder as well. There are a few other ones like carbonated beverages, anything with red or blue dye in them. So if you drink a lot of Gatorade, Mio, or any of those kind of drinks that have coloring to them, they could also be irritants. Now, not everybody's going to be irritated by the same thing. So you just got to be mindful of what you're maybe consuming and then make modifications accordingly. You're going to want to develop new habits. So a lot of guys, what they'll do is they'll stop drinking water because they're leaking. Makes sense, right? Well, the thing is that if you stop drinking water, then your urine becomes concentrated. And concentrated urine is extremely irritating to the bladder. The bladder has this beautiful inner lining to it. We call it a mucosal lining. And the lining inside of the bladder here, it starts to get destroyed the more the urine that comes in is toxic or concentrated. And as you start to destroy that lining, you're going to increase the sensitivity to the bladder. And so naturally you want to try and avoid that. So continuing to make sure that you're hydrated and that you're not predisposing your bladder to irritation. Avoid emptying the bladder too often. So a lot of men will have these kind of leaks happening, and every time they feel a leak happening, they just go to the bathroom and try to empty. But the idea is that you want to actually try and suppress the leak. So you want to use your pelvic floor muscles and squeeze them so that you stop the leak from coming out instead of just going to empty it, because then you're not really working on strengthening your pelvic floor muscles, and so they're not going to get the conditioning that they need to start working for you to eventually stop the leaks from happening. It's important that you walk 30 minutes a day to keep not only your cardiovascular system healthy, but it's also a great way to build on your pelvic floor muscle endurance. This is one of the times when men will start to notice that leakage happens quite significantly. And while you're walking, it's suggested that you contract your pelvic floor muscles at about 20 to 30%. So this isn't a full maximal contraction. This is just a very small contraction that you maintain through the entire duration of your walk. And this really helps to build up on the endurance of your pelvic floor muscles. okay? If you're really struggling and you're noticing when you're walking, you're having, you know, incredible amounts of leakage, then a penile clamp, which is what you see here in this picture, you just place it at the tip of the penis. So this is different than what we did with the tension loop when we were trying to prevent climacturia, where it was placed at the base of the penis. Now you're placing it at the tip of the penis, and you're just going to clamp it down, not crush it, but just clamp it down so that the urethra is squished and that the leakage isn't going to happen. Now, just because you're wearing the clamp doesn't mean that you don't have to work on your pelvic floor muscles. It's just to help you not be as wet. Okay, and so you'll still want to work on contracting that pelvic floor muscle at a low grade percentage. These are the estimated timelines for incontinence improvement. The hardest time to stop leakage is usually between the hours of 11 to 6, and that's because your pelvic floor muscles have had the chance to sleep through the entire night. They've had a chance to rest, and they're fresh, and they're at their strongest point first thing in the morning. And as the day goes on, we start to notice that those muscles start to fatigue, and then that's when urinary incontinence starts to happen a little bit more. You'll note if, for example, you want to go out at night and you know that you have an event or you're attending a dinner or whatever the case might be, I would suggest that you try and lie down for an hour in the middle of the day where you'll allow the pelvic floor muscles to rest, because the pelvic floor muscles are postural muscles. So they're on when you're sitting and standing, but when you're lying down, they're resting. And so there are examples of how you can do this on my website, but really it's as simple as this. You just get down onto your floor. You just put your feet up. And you can do some deep breathing. And really just focusing on the letting go or the reverse Kegel. Okay, and just giving your pelvic floor muscles an opportunity to rest. On my website, you'll see that there are some wall stretches that you can do while you're here, and you can stretch out all the muscles that go around the pelvis in an effort to try and relax the area and reduce the tension that's going on, because you're naturally going to be tightening up through the day because you're worried about leaking. So you're going to hold your pelvic floor muscles tight all day long, but you've got to also give them a rest. You can't expect the pelvic floor muscles to be able to perform at 100% if you're always using them, right? So that's a really great strategy to employ if you're having any leakage. Typically, we expect nighttime urination to improve first, sitting will improve second, and then standing is typically the last one, just because obviously you're moving around. A quick word on protective padding. The goal is to always try and wear the thinnest pad possible. This is not a protective blanket, okay? If you have the pad on, you're less likely to think about your leakage, and we want you to be focused on it. So if you don't leak at night, don't wear padding. If you don't leak in the morning, don't wear padding, especially if you're at home. You've got to be mindful and constantly thinking about what you're trying to solve. Okay, so here we're going to take our first little break. If you need to go and empty the bladder, please feel free to do so. We're going to transition now into erectile function. And then after that, we'll have one more little break before we get into the exercise. If there's any questions, I'll entertain those questions at this time. Otherwise, we will continue on. All right, so normal erectile function. To have an erection, there is a complex process of various systems in the body working together, interacting to create an erection. But one of the big ones that are involved in an erection is the vascular system. And so what you can see here is an image of the penis, basically sliced right down the front. Ouch, I know, most of you guys probably just tightened up a little bit there. But all kidding aside, this is just so that you can understand that the penis has been cut, and now what we can see is the inside of the penis. And this is kind of cool because what you see, and probably many of you don't realize, is that there's 3 chambers in the penis, and these are actually muscles. And what muscles are these? Well, they're these muscles here. So this muscle's here called the ischiocavernosus, and this is the bulbospongiosus. These muscles are underneath your skin, just underneath your testicles. And the penis is a creation of those muscles, or an extension, I should say, of those muscles. Okay, these guys here come on the bottom, and then you've got two on either side that create these big channels here. Inside of these channels, there are a number of blood vessels, particularly arteries, that fill up or engorge with blood when stimulated, either by tactile stimulation, by visual, auditory, sometimes smell or fantasies can cause a stimulation. And then also it happens several times at night. Those are called nocturnal erections. But there are those three types of erections that can happen that can create this dilation or this engorgement of blood into these chambers. And the important thing to note here is that what happens when the penis starts to engorge with blood, we're going to look at this dorsal vein, okay, the dorsal penile vein here. When the penis fills up, it starts to squish or compress that vein. And this is extremely important because you don't want the penis blood that's here to be draining out. We call that a venous leak if it drains out. So if there is insufficient engorgement of blood in these chambers, then the venous vein or the penile vein is not going to get compressed sufficiently, and the blood's just going to flow out and the erection's not going to last. This is really important because if you start to notice before surgery, let's say, because obviously the erectile dysfunction that comes with prostate surgery is more due to nerve damage, which we're going to touch on. But if, let's say, before surgery you started noticing that your erection was waning or it was starting to disappear and it wasn't as strong, this could actually be correlated to heart health. So Joe Milios coined the term heart health is correlated to heart health. And that's because if the vessels in the penis are not being sufficiently engorged, then this is actually an early warning sign for a cardiac event that's going to happen at about the 3 to 5 year mark. So if you start noticing that your penis is starting to be dysfunctional, then you want to probably book an appointment to go see a cardiologist and have your heart checked, just to rule out any possible cardiac events that could occur within the next 3 to 5 years. All right. Now, these muscles here, as we discussed, these guys are very much involved in erectile function and maintaining the rigidity of the penis. And these are the muscles that we are training when we are doing pelvic floor exercises. Okay, so the stronger these muscles get, the better the erection gets. And there is some research, lots of research actually, in normal, healthy men that show that if you train your pelvic floor muscles, you're going to have a better erection. And that was Grace Dory was really the lead here in establishing the evidence for that. Okay, let's talk about nocturnal erections. Because when you have prostatectomy, you lose all of them. And these are housekeeping erections that are extremely important because they keep blood flowing into the penis while you're sleeping. And what happens is if you don't have these nocturnal erections, then the penis stays in a flaccid state. And if you can see here, the pressure in the penis in a flaccid state is about 35 millimeters of mercury, which actually causes collagen to be produced and deposited into the penis. When the penis is in an erect state, the pressure is much greater, at greater than 70, and that actually inhibits the collagen production. So if you are no longer, as a result of prostate surgery, having erections, and you've lost all your nighttime erections, approximately 1,500 nighttime erections are lost annually from having prostate surgery, you're going to be remaining in this flaccid state, which then, as I mentioned earlier, you're going to get this plaque or this fibrotic formation starting to happen, and it's scar tissue that starts to develop in the penis. And as a result of that scar tissue, the penis is going to start to shorten, because scar tissue has a propensity to tighten and tighten and tighten over time. Okay, and that's why we continue to see this penile shortening over time. This is a beautiful image here of the nerves that are present in the area of the prostate. And so as you can imagine, when you disrupt the nerves that are around the prostate gland by cutting them and also by pulling, because the prostate gland here will actually get removed up and out through the abdomen. You'll notice that you have a scar over your belly button, and that's because that's where everything gets removed. And so that whole traction and pulling out pulls on various nerves, and then there's the whole cutting and cauterizing of nerves that occur during the surgery itself. So all of these nerves that go down to the base of the penis, all the way to the tip of the penis head. You might notice that you have some burning with urination or pain after the surgery at the base of the penis. Some people might even notice that there's some constipation issues, and the bladder just might become also hypersensitive. So all of this disruption can impair function. And we call this disruption neuropraxia. And that's why when the damage to the nerves, it will inhibit or stop the capacity to have erectile function. And this is why early penile rehab is extremely important as soon as that catheter comes out. Often people wait until the incontinence is managed, but that is not how I approach it, because we know the longer we wait, the more that collagen deposits, and then the more the structural changes start to happen. And unfortunately in the penis, the structural changes are non-reversible. So I start immediately with my penile rehab, and the strategies that I employ, fortunately, incorporate all of the components together. So we manage the incontinence, we manage the erectile dysfunction, and we manage the loss of penile length all in one technique. So what is penile rehab, right? We want to know, how do we get started on this immediately after that catheter gets removed? So there's 3 lines of treatment. The first line are these PDE5 inhibitors, probably better known to you as Viagra, Cialis, or Levitra. And these, sometimes we don't have much success with men who've had prostate cancer, because these are more for, they work on the vascular system. And so that men don't always have success with these particular drugs, but some do. But important thing about them is, particularly the Cialis and low dose, they help preserve the filling phase of the erection. And there's 6 different phases to an erection, but it helps to preserve that second phase and just keeps the blood flowing in to try and create a little bit more pressure so that that collagen doesn't deposit. Sometimes these drugs are really poorly taken. There's not enough education provided to the patient before they receive these drugs. If you eat before you take Viagra, it's not going to work. If you don't become aroused when you take these medications, it's not going to work. It's not a miracle drug. You need to have arousal, and you need to take them appropriately for them to be effective. Cialis tends to be the weekender, as they call it in France, because it has a little bit of a longer lasting time frame, where Viagra is a little bit shorter. But these are all things that you want to talk to your doctor about and get a proper education on. The second line treatments, the vacuum erection device, is definitely one of my favorites, and we're going to go into that in a little bit more detail in the next slide. And then the intracavernosal injections. Here you see the image where the man is pulling on the penis and inserting an insulin needle with a solution that's found in the injection into the penis, and this is an on-demand erection. You're going to get an erection that's going to last about an hour to an hour and a half, and it's suggested that you use it anywhere from 2 to 3 times a week. Definitely don't use it twice in a day. And if for any reason you over inject, so you've got to be very careful with the dosage. You don't want to overdo it, because what could happen is something called a priapism, which is the erection that lasts for more than 4 hours. And if that happens, that's actually a medical emergency. Okay, so you're going to want to get to the doctors as soon as possible, or the hospital as soon as possible. But this is important because it preserves that blood flow for that period of time where the erectile tissue is under that neuropraxic effect, or that nerve damage effect that does take about 2 years to regenerate. Nerves are unfortunately a structure in the body that take a really long time to regenerate. It's painfully slow, and that's why it takes such a long period of time. But we've got to keep the blood flowing in the penis. And then the third line treatment is really a last resort treatment. It's the penile prosthetic implant, and many patients are extremely satisfied with the results. But again, it's highly invasive. There's always a risk of infection, and it really should be that kind of last resort. So let's talk about this vacuum erection device, because it's truly my favorite approach to penile rehab and also incontinence management, because you can do a lot of things while you're in the pump. So this pump here that you see in the image, or it shows you basically how it works. I use something called the VacuErect pump. I have no affiliations with VacuErect. It's just the pump that I prefer. And it comes with various rings. Okay. And if you take any size ring. It just depends on the size of your penis. You want to have a ring that, you know, provides sufficient compression so that it doesn't allow for the vein to drain out the blood. And you place this at the base of the penis. Okay, you put the penis through the ring, you put the ring and the penis is out, then you just put the pump on top of that ring, and then all you're doing is while it's there, you're just sliding the pump up and down, and the penis is going to get drawn in to the pump through negative pressure. Blood is going to get sucked into the penis, and what you're going to start to see is your penis becoming erect. Now, the protocol for the pump is that you get your penis to a point where it's erect, and you don't want it to be uncomfortable, so just before the point of discomfort, and you keep it there for 3 minutes. Once the 3 minutes passes, you just pop it off, and then you have an erection that is maintained because the ring that's at the base is squishing down on that dorsal vein, and it's preventing that venous leak that we talked about earlier. Now, what you can do while you have an erection, and it doesn't last very long, not in the beginning, it could increase in time, but what you could do is a couple things. You can try to have penetrative sex, you can masturbate, or you can use this lovely device here that you see called the Manta. And men absolutely rave about the effects of this vibrator. It is designed specifically for men, and it provides a really deep penetrative vibration to the penis as well as to the area around the groin. And it really helps you to achieve an orgasm, which we really recommend that you start doing many times through the week, just to keep the area viable. Because in order to have an orgasm, the pelvic floor muscles have to contract to 100%. So it's a great way to exercise, and it's also really enjoyable. So make sure that if you have an opportunity to get your hands on the Manta, definitely try it out. And it could be a fun thing to do and use with your partners. So my research, I'm thinking when I was doing these and following the protocols that are out there to date, the most current literature, I'm thinking, well, we're sitting in here for 3 minutes. Well, why don't we use this as an opportunity to also work our pelvic floor muscles? And so while we're in here, we're going to do the pelvic floor contractions that we're going to learn in a couple of slides. And we're going to work on the slow twitch and the fast twitch fiber muscles, because the pelvic floor muscles have different types of muscle fibers in them. And some are for endurance and some are for power. And we've got to make sure that we're working on both, because they both have different responsibilities. For example, if you're coughing and it's an instant massive intra-abdominal pressure and you cough, you're going to need your power muscles, because it's going to require a lot of strength. And let's say you're going for a walk, then you'll need your endurance fibers. So it's important that you train on both. So when you're in the pump for those 3 minutes, you're going to work on those pelvic floor exercises. But then even better is what I realized is that if we want to create more size in these muscles, we want this little muscle that we're left with to be as big and as strong as possible. Well, how do we do that? We have to do some weight training or resistance training. And this is the big problem with a lot of the research that's been conducted to date, is that the intensity of the treatment was not sufficient to create a change in the muscle size. So in order to build strong muscles, there's a very specific protocol that one needs to follow, and you need to train to failure. You need to train so the muscle is exhausted. And so if, I have a lot of guys that come in and say, oh yeah, I did my pelvic floor muscles. I did a couple in the morning. I did a couple while I was at the light. I did a couple while I was, sitting down and doing some work. That's not training them to exhaustion. If I go and I pick up a dumbbell and I, do a couple curls, and then I put the dumbbell down and I go and start my day, and I come back the next, a few hours later and I do a couple more, my muscles aren't going to grow. They're going to grow if I sit there and I do 3 sets of 10 to 12 reps and I pick up weight that's making it so hard for me to finish that rep, and then I do it again and again. So that's the whole idea, is now when you're sitting in here for 3 minutes, you're going to be training your pelvic floor muscles, and then you're going to come off. You're going to go back to a flaccid state. You're going to do a second set for another 3 minutes. You're going to come off, go back to a flaccid state, and do a third set, and then come off. and then you're done. And that would be the intensity that's required. And you're going to actually, so the pump you can do once a day, but that whole protocol, you're going to actually be doing 6 times in a day. And you're going to see that in just a moment. This is just some of the work from Joe Milios, who's really been moving men's health forward. And I think it's important to mention her because if you want to read any of this, the more recent studies, she's really the one that's making a difference in men's health. All right, so we are almost there and ready to learn how to train these muscles, but we have to understand one thing: technique matters. What's been going on here in the previous research, and the reason why the results are somewhat inconclusive, is because we've been teaching men strategies that we have learned from Dr. Arnold Kegel back in the 1940s. And he adopted strategies to help women who have had children or now having incontinence and prolapse situations. And we are using those strategies that he came up with, and we're adopting them for men. But the anatomy is somewhat different. So we can't just say to men, do Kegels, okay? We've got to teach the men how to do what I call a Kegel. And you want to focus more on the front and not on the back. So Dr. Arnold Kegel would tell women to prevent the passing of gas, flow of urine, and in that kind of back to front order. But with men, you've got to focus on the front portion. And these are the 3 muscles involved in maintaining continence. We've got the puborectalis, which is at the back. We've got the striated urethral sphincter, which I spoke to you, because this blue thing here is your prostate. This is that striated urethral sphincter that you're left with. And then the bulbocavernosus, which we saw earlier, is one of the muscles that are responsible for sexual function. And the issue here is, if you can appreciate that the urethra here travels in its length, if you are trying to stop a hose from having water come out, you're going to bend it in half. You're not just going to grab it and expect the water to stop. The most effective way is to bend it in half. And so here we get this scissoring effect by the activation of these front muscles first, and they are the ones that really close down on that urethra and will be most effective in stopping leakage. What's more important here is, if we look on the slide, and this is from Paul Stratford, one of the big gurus from Australia, who's also making a big difference in men's health. And he, through transperineal ultrasound, shows very clearly here that before surgery and after surgery, there have been significant structural changes that have been undergone. And what we see here is that the bladder now has changed into more of a funnel. So it's more likely to accumulate urine, whereas here it has a little bit more of a flat shape. So that's going to make a difference in terms of urinary leakage. We also talked about the length of that urethra. It's been significantly shortened here. And then the other big important thing, why we can't use some of the techniques that we used for women, is because the bladder neck, or the bladder itself, has dropped down. And its location is much lower. So imagine here we take this bladder and we drop it down, we remove the prostate, and then we bring it down to this area. Well, what muscle? If you use the muscle that prevents you from passing wind, you're actually going to be compressing on the bladder, and that's going to cause leakage. So very important that we engage the muscles from front to back. All right, so now I'm going to give you guys one more break. And we are going to start the active portion of this. So if you need to go and empty your bladders one more time, please feel free to do so. I will also entertain questions, and we are going to get into working those pelvic floor muscles and starting to sense those muscles. All right, so if you're just kind of still hanging around, and I'll suggest you go and get a chair that you can sit on. Perhaps you're already sitting on it's a couch. I'm going to suggest you go get a harder chair, because it's going to be difficult to do this if you're sitting on a chair that is soft like a couch. Okay. Hopefully everybody's back and ready to go. So I created this chart, and you guys are all going to have access to this PowerPoint presentation, and you'll have access to this particular slide. This is really the big one, okay? And this is the high intensity exercise protocol that I highly recommend you all start doing today, okay? And and continue to do this, right? It's you can't just one day stop doing it. You don't necessarily need to do it to the intensity with which you're doing it at the outset, but you definitely need to maintain it over time, because if you don't use it, you'll begin to lose it, and you really do need that muscle. So we're going to have a seat, and we're all going to come to the front of the seat, and we're not going to be slouching, because at this point I know it's been a long presentation, and I don't want you guys to, we're probably all in this kind of posturing where we're on the back of our sit bones. So what I want you to do is start coming into the best posture that you can possibly get into, and sit on the front of those sit bones. If everybody wants to turn on their cameras at this time, I'm happy to have a look at as many people as I can see doing this, so that I can kind of give some cueing. If you're not comfortable with that, that's okay. You just have to watch and try this at home. So we're all in the front of those sit bones, and it's important to understand the difference between them on the back and on the front. And I'm just going to give you a quick little example here. So this is the pelvis, and then these are the sit bones right here. So when you're sitting on those bones. And what we don't want is, we don't want you sitting on the back. We want you to sit more on the front, and that's a better optimal place for the pelvic floor muscles. Okay, they're a little bit stronger and more reinforced in the front. I'm also going to ask you to spread your legs out a little bit. Men have a tendency to use their inner thigh muscles and their bum muscles. And so in an effort to kind of shut that down, we're going to have you lean way forward. So now you can't use the wrong muscles, because if I'm stretching your bum, you can't squeeze your bum to try and contract your pelvic floor muscles, which is what a lot of people do when they're trying to contract the muscles that are inside the body, right? The muscles that we're going after here, guys, are the ones that are found in this particular area. So they don't have any responsibility in moving you like the big bum muscles do on the outside. So let's do that. Legs a little bit spread out, and we're all going to lean forward onto our elbows, and we're going to take a deep breath in. And now, as you're thinking about lifting the penis, or drawing the nuts to guts, as Joe Melios coined, okay, or termed, you're going to try and hold that for 10 seconds. So again, let's try this. Let's take a deep breath in. And then as you're exhaling, we're going to count out loud for 10 seconds, and we're going to lift the penis. 9, 8, 7, 6, 5, 4, 3, 2, 1, and then slowly let it go. Don't let it go fast, because what if your bladder is still contracting? What if it's still trying to push out some urine, and you just let go quick, fast? Then the bladder's just going to let the urine out. So you've got to let go slowly and determine whether or not the bladder is done doing what it's trying to do. And then again, you repeat that 10 times. So let's try it one more time, and just try and pay attention to what's going on down under. Can you feel that penis lifting or retracting or being pulled inside? Can you sense that? So the easiest way to sense it, like I said, is in this position when you're starting out. Let's try that again. Inhale deeply, and then exhale, lift and hold. Make sure you're counting out loud. Continue to breathe normally. You should be able to talk while you're holding this contraction. Men have a tendency to hold their breath during this period. Don't do that. That creates even more pressure on the pelvic floor. You want to just continue on with your day. And then slowly release. And then you repeat that 10 times. Now, if you're in this position and you're feeling that and you feel comfortable with that, you can try to move into a more vertical position. This is going to feel a little bit different, and if you don't sense it the same way, then don't rush it. Just go back to where you really feel it and get really comfortable with making sure that your technique and your strategy is appropriate and it's effective. You want to be using the right muscles, because as soon as you lean back, you might notice you start to grip with your bum. You might notice you start to squeeze with your legs. You might see that your technique starts to change. And then you're going to try and do it when you're feeling more comfortable, and you're going to try and do it in standing. But again, be very careful that you're not using any muscles in the abdominal region to push down the pressure on the pelvic floor. You don't want to be gripping with the bum, squeezing your legs. It's literally just a lift of the penis. And I tell my men to do it naked in front of the mirror without a pad on. When you're doing this training, it's very effective to be able to watch and see in the mirror if you're leaking while you're doing this exercise. The idea is not to leak. If you have a pad on, then how would you know? You might feel it a little bit, but you can't really determine whether or not a lot or a little is coming out. And so if you just place a little pad on the floor and you do it in front of a mirror naked, and then you try and practice these contractions until you can successfully do it without leaking, then that's your best bet. We call that naked mirror training. Now, so that's the slow twitch muscle fibers. So those are the endurance ones, okay? And you'll want to do, like I said, 10 sets of 10-second holds with a 10-second rest in between each set. Now when we're focusing on the fast twitch fiber muscles, we're doing 10 fast contractions at a rate of 1 per second. So again, we can go back to our learning position to make sure that the technique is accurate. And here, all you're doing is squeeze, release, squeeze, release, squeeze, release. So lift the penis, lift the penis, lift, 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 lift. And you're trying to do that at a rate of 1 per second. And you should feel that contract, relax, contract, relax, contract, relax. And you're going to do that 10 times. Within 10 seconds, you're going to take a rest for 20 seconds, and you're going to repeat 3 sets of that. Okay? Remember, it's about training the muscle to fatigue. If you're not doing enough repetition, you're not going to create change. Okay? And then what you can do with this one is obviously you change your positioning, just as we did with the initial one. But what you can do is you can contract. Now this is a much stronger contraction, right? The previous one was about 20 to 30% contraction, maybe 30 to 40, and it's something that you can hold. But with this one, you are really contracting a much greater force, because what you're going to do as a progression is you're going to hold that contraction for a couple seconds and then cough. And you're going to do this again naked in front of the mirror to see if you can effectively stop a cough from coming out. Now, this does take time. It takes a lot of practice. It takes a lot of patience, okay? So don't give up too soon. It will become automatic eventually. And the only exception is for patients who have been radiated. Unfortunately, the tissues become less resilient over time, or less stretchy over time. And so they might actually notice some worsening of incontinence as time goes on. So just to recap, take-home messages: technique matters. You're Kegling, you're not Kegling. We're using new strategies. Intensity matters. You've got to train to fatigue. Pelvic floor muscles training enhances strength and blood flow to the external sphincter, which can promote healing and recovery. You're going to be performing these pelvic floor muscle exercises 6 weeks before surgery. And that was noted on the previous slide, and I forgot to mention that, but it's here as a take-home message. You'll definitely want to, if you're one of the fortunate ones that gets referred by a surgeon, and you don't need a referral for pelvic floor physiotherapy. So if you can advocate for yourself and seek out the help of a pelvic floor physiotherapist before your surgery so that you can learn how to do these exercises to make those muscles as strong as they can be before you go into surgery, that would be to the best advantage for yourselves. And the other thing is, if you happen to experience pain while you're doing these pelvic floor muscle exercises, you're going to want to get in touch with a pelvic floor physiotherapist to learn how to reverse Kegel first, because what might happen is that you're creating too much tone in the pelvic floor muscles, and then you can run into some issues because you're having pain and you're not learning or learning how to let them go sufficiently. So some of those things require some assistance and some work. And just here, these are slides again that are going to be going home with you, just some reminders of how and what you should do before you go for surgery, those pelvic floor exercises, cardio, eating healthy, drinking lots of water, making sure you're having several erections per week, as well as orgasms to keep that erectile function as healthy as possible. And then after surgery, you're going to resume those exercises as soon as the catheter is out. And you're going to make sure that you're not lifting more than 10 pounds, as we talked about, and be mindful of activities like gardening or scraping the car, especially with the winter season coming, and avoid lifting loads that cause leakage, because you're really just blowing past the current strength of your pelvic floor. Work up to it, be patient, and I wish you all the best of luck. I hope that this webinar has been informative and helpful, and I'm happy to entertain any questions at this time. Thank you so much for your attention.